All, this is Dr. Mubin Sayed. I am Content and Medical Director for React 19. Today, I wanted to discuss a study for COVID-19 and long COVID patients, COVID-19 positive and long COVID patients. The study actually says that women who have had COVID have vascular damage and the acceleration of their vascular age. This is a serious problem. The problem is that as we age naturally, our blood vessels age in sync with that. And you see that as we age, we become more, we have a higher risk of, let's say, cardiovascular events, heart attacks, strokes, etc. The study would show you, and I would demonstrate that to you, that just one event of COVID-19 in a woman can accelerate their blood vessels age by 5 years, even if the intensity of the COVID-19 severity was not that severe to go to a hospital. Even when the COVID-19 was an event that happened and they stayed at home, it was not severe enough. So this means, at least if we look at the study, that means almost everyone, especially women who have had COVID in the past, have some sort of damage to their blood vessels. And what does that mean? What does aging of the blood vessel mean? One, the hypertension occurs because the blood velocity increases. The compliance of the blood vessels, the flexibility of the blood vessel reduces. So it becomes difficult for the blood vessel to dilate as the bolus of the blood passes through it. And so the blood vessel cannot handle higher pressure and it might actually break under pressure. So increased blood pressure in such individuals can actually cause blood vessel ruptures. Increased blood speed or velocity of the blood passing through the blood vessels, when that increases because the blood vessels are now constricted, that causes further damage to the blood vessels plus to the tissues. So there are many disadvantages of aging blood vessels. So today what we'll do is the following. Number one, we'll look at the study. Number two, we'll look at the mechanism. The mechanism is majority my proposal. They only have one or two sentences that spike protein binding with ACE2 and COVID-19 infecting the endothelium of the blood vessels causes the damage. I'm the one who picked up some other studies and will present the remaining possibilities. Then they discuss various numbers, men versus women, and the aging of the blood vessel that happened. So we'll discuss that. And finally, we'll discuss what are various ways to manage the stiffness of the blood vessels. You must be aware, for example, statins are one type, blood pressure control is another way, etc. So we'll discuss those as well. The study itself does not discuss various interventions. They do allude to the idea that if we know the acceleration has happened, the aging of the blood vessels have happened, the blood vessels have become inflamed and damaged, then that indicates to us, the physicians, to manage this situation. So let's look at it together. So this is React 19. I'm sure that you've seen this site before, react19.org. And if you go down here, there are research and education. There are more studies too that are present here, more videos as well, and so on. This is a study that I want to discuss today. This is published in European Heart Journal. This is Oxford Academic. The study is Accelerated Vascular Aging After COVID-19 Infection, the CARTESIAN study. If you see here, it is 14 October 2025 issue in which it is present, published on 17 August 2025. So pretty recent study. Although the individuals who participated in it, they were from, I believe, September 2020 till February 2022. So the time frame is in the earlier COVID variant times. But the results are published now. I wish that these results were available earlier, so we could have looked at the patients in a much better way. So let's now go to my presentation and then we'll come back to the study and read some. So the background and aims of the study. Increasing evidence suggests that COVID-19 survivors experience long-term cardiovascular complications, possibly through development of vascular damage. This study aimed to investigate whether accelerated vascular aging occurs after COVID-19 infection, and if so, identify its determinants. Then here is a conclusion. COVID-19 is associated with early vascular aging in the long term, especially in women. And I want to kind of anchor this idea, especially in women. So let's go back to the study for a second and read part of the results. And don't mind if every term does not make sense. We'll look at that. But look at the men versus women difference. In sex stratified analyses, pulse width velocity differences were significant in women, but not in men. So although they said especially in women, that is also a sentence from the same study, but in the results they show that only the women had statistically significant damage to their blood vessels and acceleration of the blood vessel age, and men had nothing. So that means it is even more important for women to take care of their blood vessels and the clotting, because they definitely have had this issue with the COVID as well. Now, another comment I want to make up front, and that is about the vaccination. In this particular study, they say about 10% of the audience or participants were vaccinated. Remember, these are early times for COVID. And the vaccinated individuals had lower acceleration. So instead of 5 years of acceleration at home, COVID positive, they had about 3 years of acceleration. So vaccine helped reduce the acceleration or damage to the blood vessels. Now, this is my statement. This is nothing to do with the study. This is not the author saying, this is me saying it. I think that the data at that time did not include, there was not vast enough vaccinated individuals available. As you can tell that in this study, out of these 3,000 people, only 10% were vaccinated. There were not vast enough number of people vaccinated. There were not vast enough number of people known to have become injured, and we had not seen their injuries. So the kind of vaccine side effects that we see, that does include vascular damage and clotting. So I would believe that the spike protein, that is the mechanism here in this study from COVID, may also be the mechanism for vaccine as well. The only difference will be, in the case of the infection, the virus itself can enter the endothelium and cause disruption and damage of the endothelium. In the case of vaccine, that would not happen. And in the case of vaccine, not everybody would have the spike protein running around in their blood vessels, but a lot of people do. And we would discuss how spike protein binding with ACE2 on the endothelium would cause inflammation as well. So my conjecture is that vaccine injury or post-vaccine syndrome patients will have this similar aging to their blood vessels as well. But the study doesn't say it. So if we stay loyal to the study, then the study says vaccine actually improves the damage or reduces the damage that can happen. Okay, so the study is called CARTESIAN study, COVID-19 effects on arterial stiffness and vascular aging. People in here, September 2020 to February 2022. In some centers, so this was a study, if I go to the next slide for a second, they had conducted this study across 18 countries with 38 centers or hospitals that participated in it. 2,390 participants. Now, if I go back here, in some centers, controls, that is the healthy individuals, COVID negative individuals, were recruited from hospital staff. Why? Think about it. COVID was just starting. Everybody was, nervous about it. People were not going out. And now you're called into hospital to say, hey, you're going to be a healthy control. We want to take your blood pressure and we want to measure your pulse wave velocity. So can you please come in? The exposure to the infection and the chances for that would increase. So in many cases, or the way they articulated it, in some cases, they just simply took COVID negative hospital staff as the control. And this diagram here is a healthcare professional I drew who is holding CME certificate that she earned at Dr. Bean. Okay, so 38 centers, 18 countries, 2,390 participants. They divided these participants in 4 groups. Number 1, COVID control, COVID negative, and that was control. So that means these were the individuals who did not have COVID. Then 3 more groups of those who had COVID and who have had COVID within 6 months plus minus 3. So what were the 3 groups? One group of patients who were COVID positive, known positive, but the COVID did not become intense enough or severe enough for them to go to a hospital. So COVID positive at home. The group number 3 was COVID positive, severe enough to go to hospital, but not severe enough to go to an ICU. So they stayed in the general ward. So COVID positive, hospitalized general ward. And the 4th group was the severe one, COVID positive, hospitalized in the ICU. Now, please remember that the researchers said, we understand that those who went to ICU, they may have more comorbidities, they may have, their age may be advanced, etc. So when they did the analysis, they adjusted for these variables. 10% were vaccinated. So how did they measure the aging of the blood vessel? So there is a method called pulse wave velocity, PWV, which is used to understand the stiffness of a blood vessel. And a blood vessel that is more stiff means it is more aged. As we age, our blood vessels collect more and more plaque, atherosclerotic plaque, and calcification and fibrosis, and they keep becoming harder and harder and harder, or stiff and stiff and stiff. So when a blood vessel becomes stiff, it becomes less compliant. Stiff and compliant are opposite to each other. When a blood vessel is stiff, it is less flexible. A flexible blood vessel is called a compliant blood vessel. So when the heart pumps out the blood, that blood is going to pass through the blood vessel. So there is a bolus of blood that's going to pass through the blood vessel. The blood vessel has to open up to allow the bolus to pass through it. You can actually feel that, but by putting your hand on your pulse, on the wrist, for example, and you can feel that the blood vessel, the pulse kind of arises and goes away. So what is happening with each beat? The blood is passing through the heart to aorta, to the branches, eventually to the branches of the arteries that are going to the hand, and you can then feel it over here, that with each beat there is a pulse that happens. Now imagine if the blood vessel is stiff and it does not flex with the blood passing through it. What that does is that increases the velocity of the blood flow. It is very similar to if you are watering the garden, and if you squeeze the mouth of the water hose, the water would come out in the form of a jet with a higher velocity. Why? Because as soon as you reduce the diameter, the velocity increases. A blood vessel that does not comply, a blood vessel that does not flex, is a stiff blood vessel. That is equal to V reducing its diameter, and the blood would flow fast in it, the velocity would increase. So there is a way to measure that velocity in us. What they do is they have a device, which is, of course, it is called carotid to femoral pulse wave velocity measurement device. What it does is the following. That device is hooked up to an EKG machine. So it knows every time heart beats. So it knows when the blood comes out. Then the carotid artery, which is a pulse over here, there is a device or a listening device that is put on top of the carotid artery, and that is also hooked up to the device. So device knows when the blood came out of the heart and when did it reach here. Similarly, the device also knows when it reached the femoral artery. Femoral artery is if you put your hand at the beginning of your thigh, upper leg, at the end of your pelvis and the beginning of the thigh, if you put your hand kind of on the inner side, but not too much inside, still on the front. That little area is called femoral triangle. In the femoral triangle, there is a blood vessel called femoral artery. And there is a listening device placed on femoral artery as well. And the sounds are picked up from there too when the pulses are going. So now the device knows, as soon as the heart beats, it knows it through the EKG. When the pulse reaches the carotid, it knows it, how much time did it take to reach here. Then when the blood passes through the aorta and goes to the femoral artery, it knows it, when did that blood pulse reach the femoral artery. Now the question is, what are the distances? So we can then measure how much time did it take to traverse that distance. So there are various ways. One way is that people can, the technician can measure from clavicle to here and then from clavicle to femoral and input that into the machine. Another way is that if you know the height of a person, from there is a formula to calculate reliably the distance that it would take, or the distance between the femoral artery and the carotid artery. So once they know that, and once this apparatus runs, we know how many meters per second is the velocity of the blood. So now let's look at some of those numbers. So this is a different study from where I took this table. I have the study reference down here. In this study, what they did was they wanted to measure various age groups and the velocity of the blood in their blood vessels. So remember, the slower velocity means the blood vessel is compliant, it is flexible, it can dilate, and the blood would travel slowly. The higher the velocity means the blood vessel is stiff. It does not comply, it does not open up that much, and so the blood has to kind of rush through it. So look at it. 10 to 19 years of age, the mean pulse wave velocity is 5.04 meter per second. 20 to 29, 5.86, 30 to 39, 6.32, etc. In this study, not this study that I'm showing the table, but the study that we are discussing, in the blood vessel acceleration of age study, they had their cohort 35 years of age to 65 years of age. So this area, 30 to 65, this is the group that they were measuring. So look at the numbers here. 6.32, 6.85, 8.15, 8.47, 9.01. Now, what did they find? This is the crux of the whole discussion. In women, what they found was COVID positive, not hospitalized, that means in the home, plus 5 years of additional aging of the blood vessel occurred. COVID positive, hospitalized but not in the ICU, plus 5 years of aging. COVID positive and in the ICU, 10 years of aging. So if there's a woman age 50 ended up in the ICU for oxygenation or whatever, she came back with her blood vessels age of 60 years. Now, if a woman is of 60 years of age and her blood vessels age by 5 years additional, her risk of cardiovascular events increases by 3%. So it's not only that, hey, some aging occurred. No, the risk of cardiovascular events, the strokes and the heart attacks, increased as well. Now let's look at men. If you see here, for men, all the p-values are not significant. That means nothing significant changed. So primarily, this effect was observed in women. So now, the possible mechanisms. All of this is, other than the original study saying that spike protein or the virus binding with the ACE2 enzyme, then disrupting the endothelial cell may be the mechanism. Everything else is mine here. So if it is incorrect, that is my mistake. If it is correct, that is me presenting it, but this is not the study. So here we know that SARS-CoV-2 has spike protein on it. This is also an important one. I did this discussion in another lecture as well for React 19. So in our body, to control the diameter of our blood vessels, we have things like nitric oxide, epinephrine, and we also have angiotensin 2. See the name angiotensin? the thing that produces tension in the blood vessel. So the name of this molecule is that it causes the blood vessels to become constricted, or the blood vessel diameter reduces, or it causes vasoconstriction. So our liver makes a molecule called angiotensinogen. Our kidneys make another molecule called renin. They both together make renin-angiotensin aldosterone system, or RAAS system. When we need to constrict our blood vessels, for example, for some reason we need to increase our blood pressure, for example, what happens is renin acts on angiotensinogen and converts that, breaks it down into a molecule called angiotensin. That molecule, angiotensin, over here, this little guy on the left top, when this molecule is passing through the body, when it passes through lungs, in the endothelium of the lung, in the blood vessels of the lung, on the cells, endothelial cells, that is the inner surface cells of the blood vessels, there is an enzyme called ACE, angiotensin converting enzyme. So when angiotensin binds with the ACE enzyme, ACE converts that enzyme, the angiotensin, into angiotensin 2. Angiotensin 2 molecule then circulates in our body. There are receptors on our tissues and blood vessels which are called AT1 receptor and AT2 receptor. Angiotensin binds with these receptors, and what it does is it is vasoconstrictor. That is why the name angiotensin. That means it can increase blood pressure and velocity. It is pro-inflammatory, angiotensin 2. It is a potent pro-inflammatory molecule. It increases reactive oxygen species production. It reduces antioxidants in the body. It promotes inflammation. It promotes proliferation. It increases the immune system's activity, movement, increases the number of cells that are working for inflammation. And it causes fibrosis. Fibrosis means a tissue gets more collagen and fibrin. Now you might be saying, well, that's a good thing. No, it is not. Our tissues have a finite space in them, which is filled with some functional tissue and some collagen fibrin-like material called matrix. If we increase the collagen and fibrin there, if we cause fibrosis, then we'll have to kill off, in the same space, we'll have to kill off some of the functional tissue. So if the functional tissue is gone and replaced by collagen and fibrin, we have a huge problem, and that can never be recovered. Angiotensin 2 does that. However, our body knows that this is not a molecule that we should keep it around all the time because it can cause all this damage. So when angiotensin 2 is formed, it does its function. Then there is another enzyme on the endothelium of the blood vessel. That other enzyme is ACE2, angiotensin converting enzyme 2, which became very popular with the SARS-CoV-2 because SARS-CoV-2 binds with this enzyme, the spike protein. Originally, the function of ACE2 is to bind with angiotensin 2 and convert angiotensin 2 into angiotensin 1 to 7, another molecule. Interestingly, angiotensin 1 to 7 has all the opposite effects of angiotensin 2. Angiotensin 1 to 7 works on an enzyme called MAS. It causes vasodilatation. Remember, angiotensin 2 caused vasoconstriction. Angiotensin 1 to 7 reduces inflammation. Angiotensin 2 causes more inflammation. Angiotensin 1 to 7 reduces proliferation and fibrosis, while you saw that angiotensin 2 causes that. So they both are kind of in balance with each other. But there is a problem in this whole story. That problem is, you might be saying, hey, angiotensin 1 to 7 is an awesome molecule. We need it. Good. We do need it. But angiotensin 1 to 7 is made from angiotensin 2 by ACE2. So look at this diagram. If we make ACE2 busy with a spike protein, virus or vaccine, if you stay loyal to the study, then they're only talking about the virus. If we occupy the ACE2, what will happen is a lot of angiotensin 2 is being formed. Who was that molecule? These molecules were supposed to become angiotensin 1 to 7 by ACE2, but ACE2 is not working. Either it has become downregulated by the spike protein, or it is just occupied by the spike protein, or if it is a virus attached to this spike protein, then the virus has gone into the cell, endothelial cell, and is damaging the cell. The summary, the outcome is there is not much ACE2 available to convert angiotensin 2 to angiotensin 1 to 7, the bad molecule into good molecule. The result, we end up with a big amount of angiotensin 2 running around in the body and causing inflammation, causing proliferation, fibrosis, vasoconstriction. On the other hand, angiotensin 1 to 7, which are supposed to counter all of this, is not being formed because ACE2 is downregulated or disappeared or not working. At the same time, the platelets that are passing through the blood vessels, they become activated because of all this inflammation that is happening, plus a spike protein that is present, and the platelets start becoming clotted as well. They start making plugs. They even trap red blood cells in those plugs, and we end up with clots. So not only we have the blood vessel inflammation, we also have platelet clotting, which would further cause damage to the blood vessels by occluding various areas of the blood vessel or sticking to them. The result is this inflammation of the blood vessel can then lead to stiffening of the blood vessel, fibrosis of the blood vessel, atherosclerotic plaque formation, etc. So then the question is, what are the interventional approaches? So I'm going to talk about a device I have, or React-19 have, no strings attached with them. But I thought it is interesting, and you can look at this device or similar devices. This is a Withings device, about $500. This is not something that React-19 or I am recommending or endorsing, but this is a device where the pulse wave velocity can be measured by this weighing scale. In addition to, it does another 40 other measurements as well. So knowing pulse wave velocity in this day and age of COVID-19 and vaccine injuries, I think is very interesting. If I was able to, I would have gotten it. I did not know in time. I just found this now. So anyways, here is a device that can help with the pulse wave velocity. Otherwise, maybe just discuss with your doctor as well to say, hey, can I get my pulse wave velocity numbers just to see if my blood vascular aging is not more than expected. Now, the interventional approaches. This again is not something that the study said, it is me. So any good or bad of this all is me collecting this data. And again, I'm not presenting this to you as a suggestion to use as a treatment, but something to discuss with your doctor to say, if there is an aging of the blood vessel, what do you think I should be doing? So for example, statins are a very much known drug that are used to reduce or stall or stagnate the atherosclerotic plaque formation. ACE inhibitors and ARBs are also used, and I think you can understand why if I go back for a second here. So when the ACE2 enzyme is in trouble because of these spike proteins, and we are accumulating a bunch of angiotensin 2, which is causing inflammation and fibrosis and all those bad things, then we can at least try to reduce this evil molecules pile. And how do we reduce it? One possibility is to block the ACE enzyme so that angiotensin is not converted to angiotensin 2. And so we don't have more angiotensin 2 to cause a problem. Other possibility is to use ACE angiotensin receptor blockers, ARBs, which will bind with these 81 and 82 receptors and kind of block the angiotensin 2 from doing its action. So either reduce the production of angiotensin 2 or reduce the action of angiotensin 2 by using ACE inhibitors or angiotensin receptor blockers. So I hope that makes sense. Going back to the interventions. Then omega-3 fish oil with tocopherols or vitamin E. Omega-3s are very important to discuss with your doctor. Lifestyle, morning walk, near infrared light, forest bathing, all of those light exercises, they help a lot. Then antioxidants, anti-inflammatories, curcumins, vitamin C, vitamin D, etc. Blood pressure optimization, this is very important. If the blood vessel is already inflamed and the pressure is already increased because of stiffness of the blood vessel, on top of this, If the patient already had hypertension and that whole thing is now uncontrolled, then that would cause even more blood vascular damage and increase the risk of cardiovascular events or blood vessel ruptures. Smoking cessation, diet improvements, etc. What else could be there? For example, resveratrol is known to reduce, at least in some studies, to reduce the production binding of the spike protein to the ACE2. So let me actually show you a quick study as well before you said, why did I bring up resveratrol? So look at this randomized double-blind placebo-controlled proof of concept trial of resveratrol for outpatient treatment. So here, what they said was, outpatient in this phase 2 study treated with resveratrol had a lower incidence compared to placebo of hospitalization, 2% versus 6%. COVID-19 related ER visits, 8% versus 14%, and pneumonia, 8% versus 16%. So resveratrol is a possibility. Then mitochondrial, help, for example, CoQ10, methylene blue can be useful, but be very careful, talk with the doctor. Spermidine is useful, etc. Exercise, near infrared light, forest bathing. So these are some of the management approaches, but before that, one must know what is the situation with their blood vessels. So either buy a device or get that test done, then discuss with your doctor to say, this is the situation, how do we move forward? So this is the discussion. Thank you very much for watching, and I'll talk to you again.